Hey, welcome everyone. I'm so glad that you could join us today for the launch of our new resource, the Guide to Accurate and Compassionate Reporting on Pregnancy and Substance Use. My name is Rebecca Griffin. I am the Communications Manager with the Bixby Center for Global Reproductive Health. We are a hub for sexual and reproductive health work here at UC San Francisco, and we have members who are clinicians, researchers, and staff, and we work to advance reproductive autonomy through research, clinical care, training, and advocacy. We came together to create this resource because we believe that pregnant people who use substances deserve care that's grounded in dignity, compassion, and evidence. We want people to be able to get the care they need and the support to have healthy lives and families. And we know that that depends a lot on the cultural narratives around these issues and the policies that extend from those narratives. This has always been a really critical issue, but there is a constellation of rising issues that adds more urgency to this. One is the increased surveillance of pregnant people and criminalization for pregnancy outcomes that's intensified since the Dobbs decision. There is the increased push for fetal personhood, as we've seen most recently coming out of the Alabama court decision on IVF. We have a lack of available treatment options for people with substance use disorders, and also a growing recognition that punitive policies, including involvement of the child welfare system, don't work and are actually causing more harm. And the burden of that harm falls the hardest on Black, Indigenous, and other people of color. So we know the cost is really high when we get this wrong, and it's really hard to disentangle these narratives and the policies that come out of those narratives. So to help you navigate these complex issues, we assembled an amazing group of people who are experts through clinical care, research, advocacy, work, and lived experience to create this resource to support you in getting this right and serving your readers and the people who are impacted by these issues. So a little bit about what is in the resource. There is a quick one-page reference guide that you can download that has some do's and don'ts. And then there is a more in-depth resource that goes into detail on things like why this matters, root causes, and putting substance use in context, what the evidence tells us about pregnancy and substance use, and some suggestions for aspects of the topic that deserve more media attention. So for today, we brought together some of those experts for a background conversation with you all to add some depth and to bring to life what's in the resource and hopefully to inspire some ideas for future coverage. So we'll have a roundtable discussion with our panelists, and then we'll open it up to questions and answers from all of you. You can put your questions in the box at any time. So to get us started, I'd like to ask each of our panelists to introduce themselves and to share a little bit about your relationship with this topic. Nika, do you want to start us off?
Morning, everyone, and thank you all for joining us. Thank you especially to Rebecca for hosting us. My name is Nika Seidman. My pronouns are she and her. I am an OBGYN at San Francisco General Hospital, which is the city safety net hospital in San Francisco. And I work with a program that's called Team Lily, which provides wraparound multidisciplinary services to pregnant people who are experiencing homelessness or have substance use disorders or who have significant mental illness. And I'll pass it to Jamie.
Hi, everyone. Thank you for being here. My name is Jamie Lang. I use she, her pronouns. I work at a local nonprofit in San Francisco supporting people in pregnancy who may be experiencing homelessness, substance use disorder, and other adversities. I am also an advocate in my community for housing and treatment on demand related items, and I'm formerly chronically homeless. I am a person who used drugs and found recovery in pregnancy. And I'll pass it to Joyce.
Joyce, you're muted.
Sorry, guys, I'm on mute. My name is Joyce McMillan. I am a person with lived experience. I am the founder of JMAC for Families, which is just making a change for families, and Parent Legislative Action Network, which is the legislative arm to JMAC. I work to make changes and to educate the community so that they understand it's okay to look at harm reduction, not to criminalize and not to demonize people for utilizing their ability to make choices. Our goal is to be supportive of people and not punitive or
Looks like Joyce froze, and maybe Sarah, you want to go ahead and introduce yourself?
My name is Sarah Roberts. I use she, her pronouns. I am a professor in the OBGYN department at UCSF, and I am a public health researcher who studies policies and healthcare practices related to pregnant and birthing people's drug use, including racial inequities in these policies and practices.
Great, thank you, everyone. Thank you all so much for being here. So to get us started in the discussion and talking about the importance of getting this right, one of the things that we highlight in the resource is a piece the New York Times published called "Slandering the Unborn," which was a piece that highlighted news organizations' culpability in spinning out a moral panic about crack cocaine in the 80s based on bad science and racist stereotypes. And in that piece, they warn that without a really mindful approach, that the results can be irreversible. So can you each speak a little bit to the ways that you see that the impact of these sorts of narratives in your work?
I'm going to kick us off. Thanks, Rebecca. So I work in a clinical space, and the goal of our work is to welcome people into clinical care. And narratives such as this have made that work tremendously more challenging. I think that comes from two perspectives. Number one, on the side of providers, we hold in ourselves growing up in the 80s, 90s, and then kind of even today, the narratives around, I don't know if people have heard the term oxytots, but babies that are exposed to opioids in pregnancy, that narrative is continuing. And what happens is that we carry those images, those stories in our brains and project them on to the person who's coming in and end up blaming the pregnant person. What that leads to is discriminatory care, care that is delayed, care that results in misdiagnosis. Just as an example, less than a year ago, we had a pregnant person who presented to an emergency room with a substance use disorder, who was experiencing homelessness, who had extreme abdominal pains. The emergency room diagnosed her with constipation when in fact she was in labor. Every policy of that emergency room was broken and sidestepped in that diagnosis. And I think, honestly, that's because she received substandard care because people thought that she was less than and not worth taking care of. And we see that all the time. And patients, our clients and people have experienced that. They've either experienced that discrimination and that mistreatment themselves, or their community members have experienced that. And what that leads to is people feeling like they're either scared of coming to the hospital because they fear that they're going to experience blame and discrimination, or they are scared of coming into the hospital because they know that they are going to experience inadequate care and their needs are not going to be met. And so, again, we fight those narratives every day, both on the side of clinicians and trying to help rebuild trust with our clients to help them know that we are really trying to reverse those attitudes and undo those wrongs. But it is truly an uphill battle. And I will pass it to Joyce.
Can you just repeat the question for me? I went silent for a few minutes. I'm on Amtrak.
Sure. So this is just if you could speak a little bit to how you see the harm of some of these narratives about pregnant people who use substances and the work that you do.
I see the harm to be great. The harm shows up in many different ways. One of the ways is over surveillance or surveillance at all, right? Because we shouldn't be looking to just surveil people. We should be looking to support. And that means having conversations with people, finding out what it is that they need and how to keep them and or their children safe. One of the ways that it shows up negatively through the surveillance is the separation of families. As an example, if you go to a hospital for prenatal care or during the birthing process or postpartum, and they're drug testing you, They're taking samples of your blood and or your urine for reasons only to report you to the local child protection services, when the hospital is actually charged with treating you if you have any type of disorder, including substance. So they're farming off their work to an agency that is not equipped to deal with what the concerns are. Another punitive way is through incarceration and through telling people that they have to remain abstinent. All of these things are controlling issues, and they're of a carceral mindset. And I would say steer away from that. And just like the Oxycontin baby, I remember years ago, there was the crack baby myth, and studies showed that children who were separated from their parent at birth or at any time during the crack epidemic fared worse than children who remained with their parent who got treatment alongside having their child in their custody. And I will pass it to Sarah.
Thanks, Joyce. So what I would say is that most of the state level policies and like Joyce was talking about, and many of the healthcare practices that Nika was talking about related to pregnant people's drug use that we see now emerge in response to the crack baby panic. These are policies that focus on punishment, allow criminal prosecution or civil commitment, requiring reporting to child welfare, and define use during pregnancy as child abuse and neglect. There are healthcare practices that focus on urine drug testing, exactly what Joyce said, as a form of surveillance for possible reporting to child welfare. And I think what's important to remember is that even the policies that seem like they're supportive, like giving pregnant people priority in terms of entering treatment, actually emerged in reaction to those punitive policies. They weren't actually developed in any kind of community engaged way that actually was about meeting people's needs. And what that means is that unfortunately, none of the policies that we have in place actually meet people's needs. They're not helping people. They're not supporting people. And so we have a whole set of policies related to pregnant people's drug use that emerged from the war on drugs era crack baby panic. And unfortunately, they're all ineffective and in fact often make things worse for the birthing person and baby. And I think the other thing that's really worth remembering is that similar to the stereotypes related to that crack baby panic, there's a lot of racism embedded in these policies and in these practices. And healthcare providers test more Black than white patients' urine for drugs and also report more Black than white patients to child welfare. Thank you. And Jamie, sorry.
Thank you. I think for me, everybody is going to have a unique experience, and I feel like the majority of that is not captured in the media. But personally, prenatal care was on the back burner. I had other things to worry about, like housing. What was I going to eat for breakfast? I had not had a shower for I don't know how many days. I'm wearing very dirty clothes. I probably smell. If I leave my tent, the police could come and take it away. So I feel like accessing care was very challenging for me, and there was a lot of pressure for me to access care, but actually I had a lot of other things that I needed to take care of before I could do that.
Thanks all. So I want to shift a little bit to one of the things that we see a lot in news stories is they're often responding to new research that's come out around pregnancy and substance use, and a lot of times they make very strong claims about the danger of various substances. So Sarah, can you talk a little bit about why it's so hard to design good research in this area and how reporters should approach covering new findings?
Yeah, thanks, Rebecca. So as Rebecca said, it's really, really, really difficult to do research that isolates the effects of one substance during pregnancy. People who use one substance often use another substance, for example, cannabis and tobacco, or have other exposures, for example, to environmental factors, or in navigating a lot of other things in their lives, like what Jamie was talking about. And when these exposures, when these other things going on coexist to the extent that they do, it's really, really difficult to disentangle which exposure is actually causing the problem. The early studies for crack cocaine did this. They didn't, in researcher language, control for poverty or exposures to other substances like tobacco. And so once they did, what seemed like devastating effects of cocaine were no longer seen. Because epidemiologists and other researchers tend to study one exposure at a time, the papers that are published in journals also tend not to put the findings into context. So how do any of the adverse effects that people are seeing compare to the effects of other things? So things like not getting enough physical activity, living next to a highway, eating too many cookies, or even other substances that we have a large body of evidence about, like alcohol or tobacco. And so when people present these findings, they can seem devastating when in fact they're in line with other exposures that we regularly accept and respond to much differently. So as journalists, here's a few things you can do. You can ask questions like, how do you know it's this substance and not something else that's causing this adverse effect? How sure are you about this? You can also ask people to put their findings into context. What does this effect mean? How does it compare to the effects of tobacco, of alcohol, of a wildfire? And doing this can help reduce what we call a moral panic, or what we think of as a moral panic, that leads to more of the punitive and stigmatizing policies and healthcare practices that unfortunately just don't work.
Thanks, Sarah. So building on that, I'd love to hear from you, Nika and Jamie, a little bit about what we do know about substance use during pregnancy and what treatment looks like for pregnant people who use substances.
I think treatment is very different for everyone. There's not like one plug-in to treatment. It is like linear. There are many ways to access treatment. Treatment just looks very different for every single person. And I feel like I think when you talk about like shock reporting, and I will talk about the person who delivered a baby on the sidewalk here in San Francisco. It makes it really challenging for people to come back from that. Like, how do you recover when you have reporting of you delivering a baby on the sidewalk? It's not fostering an environment for recovery and healing. I could see from a reporter's perspective how that could bring attention and resources, but actually it's making it really challenging for the person affected.
Thanks, Jamie. And kind of building off that, the way that we approach treatment, first and foremost, is to try and make anywhere that someone presents for care an open door. Again, going back to the context in which we are working, this moral panic, this blaming of the pregnant person, this obsession with what is happening to the baby, as opposed to thinking of this as a dyad, right? We work really hard to try and make, if the person presents to the emergency room, to urgent care, to a needle exchange, to a shelter, and discloses to someone that they are pregnant, or to a street outreach worker. In that moment, we work really hard to make the first response be, thank you so much for sharing. Thank you so much for having the bravery to walk in the door, because we recognize how tremendously hard that is, either because you are facing so many other priorities in your life, or because you are terrified that someone's going to call child welfare, even though you're still pregnant, the fetus is still inside of you. Just for the record, in California, we do not call child welfare on pregnant people, even though that happens all the time. And ironically, it's on child welfare to tell the person who is reporting, hey, there's still a fetus, they're not a baby yet, and so you cannot make this report yet. So again, we're fighting all of that in our approaches to treatment. So approach number one is to make sure that wherever someone has the bravery to present, that they are welcome and into care. The second piece is just what Jamie said, to recognize that people have different goals. For some people, that goal is going to look like parenting, is going to look like stop using drugs to get housing, and to go down that journey. For other people, that's going to look like cutting down on their substance use, to using harm reduction to use drugs more safely. and for that child to go with another family member. For other people, that's going to look like actually not focusing on their substance use at all, just focusing on housing. And really, our goal is to meet the needs and priorities of the person in front of us, recognize that they know the important kind of prioritization of their treatment path, and that sometimes those other needs need to be met first. And we hear that all the time, especially in San Francisco, and especially from our clients. We'll hear, the best way for me to stop using methamphetamines is to have a safe place to sleep. And until we meet that goal, talking about stopping methamphetamines is not a useful conversation. So we really work hard to listen to the person in front of us, recognizing that they know the best path to whatever treatment looks like for them, and supporting them in those goals first, even though the system so often is in opposition, telling them to prioritize other things first. Rebecca, I'll pass it back to you.
Thank you. So I think you all have touched on this a little bit already, but just to emphasize, so there are a lot of approaches to this issue in policy, in the healthcare system, in the child welfare system that were maybe well-intentioned, but have proven to have negative impacts on pregnant people and their families. Anything you all want to add in terms of areas here where we want to really be bringing a critical eye?
Rebecca, do you want me to kick it off and then I'll pass it off to Joyce? Great. What I would say is that unfortunately, from my research and research from others who are studying state level policies related to pregnant people's substance use, what we found is that the policies, as I said before, aren't effective and in fact actually seem to make things worse. In particular, research has not found that mandating child welfare reporting related to pregnant people's drug use keeps babies safe, nor that drug testing birthing people or infants changes the care that birthing people or infants receive. Instead, the policies relate to pregnant people avoiding and disengaging from care and treatment, increase some of the adverse outcomes, health outcomes for both birthing people and babies, and making it more likely that healthcare providers will involve child welfare, particularly for people of color. The other policy that I want to just draw attention to that we often don't focus on, in part because it just seems innocuous or seems like well-intentioned, and so it's probably just fine, are things like mandatory warning signs. These are the signs that you might see in places where you can buy alcohol, for example, that warn about possible risk of birth defects, or that exist now in some places related to cannabis. They seem at face value to be pretty innocuous. Like, what would be the problem of posting a sign like that? Unfortunately, across a whole bunch of different studies that I've done, my research has actually found the opposite. They do not relate to decreased use but do relate to a whole host of adverse infant and maternal outcomes. Importantly, people who use cannabis, for example, don't trust the information in these signs and actually view them as increasing stigma, which connects back to some of what Nika was talking about earlier, of how these images and these ideas get into people's heads and influence how health and service professionals are interacting with people. And what comes up a lot is that a lot of researchers publishing on cannabis and pregnancy, or a lot of go-to clinical experts, ask for their views. When asked what should be done, they make a comment that policymakers should issue warnings. It seems like an obvious solution. Unfortunately, it doesn't actually help, and it probably makes things worse. Which may sound surprising, but given what we saw during COVID in terms of lack of trust in messages from public health authorities, it isn't actually surprising. So I would encourage you as journalists, if a researcher or a clinical expert makes this recommendation, makes a recommendation that warning signs or warnings be issued, ask them what evidence they have that doing so will work, and avoid restating their recommendation unless they have evidence to back it up. I see Joyce.
Heard you say you were passing to me, so First, I want to apologize to everyone for being on the Amtrak during this time. I knew this meeting was scheduled, but the person who scheduled misunderstood the block of time I gave them, and I ended up on the train. So I want to apologize. But I would like to say that what I would hope journalists would do is stop listening to elected officials and other people who seek to punish families for being different, um, for not having the same moral compass that they have, and listen to science. Because the politician who said that crack babies were going to grow up to be a certain way was not correct. And it was their policy that actually caused the child harm, because their policy led to the separation of families. I think it's really important that we listen to, read, know, understand, clarify, and verify whatever is being said through science. We separated families for years and years and continue to separate families for reasons related to the use of substances, when, to be honest, not that I am promoting the separation of any family, cigarette smoke during birthing process and alcohol use are the most dangerous drugs. But we have picked out a specific handful of drugs that we want to attack. And I don't think any drug should be utilized to punish a family. But if we're talking about science, the ones that's most dangerous would be nicotine and alcohol. I would also reporting is very harmful because it alienates people from the care that they need. Sometimes someone could have something going on with them health-wise, and it'd be important that they see a doctor, but they avoid seeing a doctor for the fear of being reported. Doctors and other professionals, regardless of what that profession is, should be there to support families, and they should not be there to report them to anyone. They should be there to simply do their job, and their job should be to care for another human being in the best ways possible. And with that, Rebecca, I will pass it back to you.
Thanks so much, Joyce. Jamie, did you want to add on this one of areas to bring a critical eye?
Yeah, I'm just sitting here listening to everybody thinking about what it was like for me accessing care. And, the first doctor that I came into contact with recommended that I have an abortion just because of my situation. No access to substance use treatment or prenatal care, or just a referral to the clinic for abortion. And that was not the path that I decided to travel down. But even accessing other resources like housing, I was not pregnant enough. I was like on the street until I was 8.5 months pregnant before they believed that my pregnancy would turn into a baby. So I was not eligible for family housing until the end of my pregnancy. So I literally was on the street until just about the very end of my pregnancy. So I feel like, people were not considering that the baby's needs are also the same needs as my own, or how we have like different needs.
Nika, did you want to jump in on this one?
Yeah, I wanted to build on what Jamie said. That story of people being unhoused, unsheltered until the very end of pregnancy is so real in San Francisco and around the country. And our policies make absolutely no sense. There is very direct correlation, just as an example, between housing status and pregnancy outcomes. And if we really, even if we are going to continue to be as obsessed only with baby outcomes, if we really care about those, then we should be housing people from preconception onward. And so our policies don't make sense in terms of both the birthing person and the child's outcome. And much more importantly, what Jamie said, what we know is that policies that focus on the dyad, that focuses on caring for the birthing people, will help the child. That is the only way to help the child. And our policies really don't reflect that at all, particularly in terms of housing. I think another good example of that is how in San Francisco too, we will house people who are pregnant. Then if they have a miscarriage or abortion, we take that housing away. Many people who have a miscarriage want to get pregnant again. So then they are unsheltered. And this happened to one of my patients just a few weeks ago. They are then unsheltered for a period until they get pregnant again. They then get into that line that Jamie talked about again. And all we are doing are creating this vicious cycle of bad outcomes. And the policies don't make sense in terms of health. They also don't make sense in terms of cost, because we are then result in preterm births, which are more costly and more challenging from a parenting perspective as well, because babies stay in the NICU, they have special needs, they have developmental challenges, not all the time. But again, this is direct reflection of housing, not even substance use. And again, that directly relates to what Sarah said about these other topics that are almost always at play when we are looking at outcomes of substance use in pregnancy. That was a tangent I didn't mean to go on, but I'm going to go back to Rebecca's question about other types of topics that we want to bring a critical eye. The two other pieces I wanted to mention, one were about coercive treatment. We know that in people who with lived experience and from people who are treating and helping and supporting people with substance use disorders, that coercive treatment doesn't work. People need to go into treatment when they are ready for treatment and when they are offered treatment that makes sense for them and their lives. There's actually, and we see this all the time, of people being forced into treatment and then dropping out and, quite frankly, having overdose, significant morbidity and mortality. And coming back from that is incredibly, incredibly hard. So one of the narratives I hope that we can focus on more, especially in light of San Francisco's recent passage of more policies around coercive treatment, is to think critically about what those outcomes look like, because at least in my clinical experience, they don't work and are in fact harmful. The last kind of narrative that I wanted to highlight, in contrast to Jamie's narrative about, or description of those kind of shock value stories, are the stories of the savior narrative of providers, of child welfare, of foster families, saving babies. And we know that, yes, there are support teams that are supporting pregnant people and their families along the way, and that the person or the individual that is doing the work is that individual. I mean, that has been on a tremendous journey to get to that point, again, facing all of those barriers that we've talked about, discrimination, mistreatment, their willingness to trust that and trust us to engage in a care team and support them is really one of the most radical acts of bravery I've ever seen. And so to discount that by focusing exclusively on the provider really is not helpful. In addition, the last point I wanted to make was I often see these stories of foster families saving babies, and this narrative that we are missing, which I really appreciate Joyce of uplifting, are the harms of foster families, not in terms of that family, but the harm of separation. There is such good data in the pregnancy care and postpartum literature about the importance of keeping families together, of parents and their babies together, and the harms of separation in terms of effects on child development, in terms of effects on children later on going into and being able to develop loving relationships and trusting relationships with other people in their lives. I see this every day when I look at the patients in our clinic, the people who are affected by homelessness and substance use disorders. The vast majority grew up in the foster care system. If that is true, we can't be uplifting this system as one that is saving babies. It can cause tremendous, tremendous harm. And we also, and that's not even looking at the stories of the birthing parents. So I really hope that we can bring a critical eye to looking at these savior narratives, these narratives that are only showing one type of positive, and recognize that Yes, there are complexities in thinking about how to support a birthing person to take care of their child in the context of substance use. And you have to weigh those against the risks of foster care, there's also tremendous data around on how the risks of those and the harms of foster care that can be tremendous, again, from separating families. So I would love to see more balanced reporting on those weighing of harms and risks.
Thanks, Nika. And so you all touched on this a little bit in the last question, but just to put a point on it, one of the things we talk about in the resource is using a reproductive justice framework when talking about this issue. There's more information you can see in the resource. Reproductive justice is a framework created 30 years ago by a group of Black women that includes, honoring people's intention to have children, to raise those children in safe and healthy communities. So can you talk a little bit more about the problem with some of these narratives that pit pregnant people against babies, and about the importance of parenting and supporting people as a healthy family unit? Jamie, you want to start on that one?
Yeah, I mean, I could just go back to my experience where it does feel like it's very hard to recover when the culture is that you are the problem, when you are just a parent who is trying to survive or trying to become a parent, when you are the one who is the problem or the disease or the harm. How does one recover from that? How, in a culture where you're the enemy, how do you become not the enemy? And I think that has a lot to do with what is reported in the press. We need to create an environment where it is fostering recovery and healing and support for people who want to do that.
Thank you. Joyce, did you want to jump in on that?
I do. I just want to say that it doesn't make sense to understand that a substance disorder is a medical issue, but punish and take children from their families for having it, when we don't take children from their families for having diabetes, cancer, or other health disorders. And so it's the reason that they swoop down on us, but it's the dishonesty in saying that they're helping, because help isn't help if it doesn't help. Parents who experience the separation of their children experience extreme trauma from that separation. Sometimes they develop mental health issues, or if they already have mental health issues, they can be exasperated. And so there's nothing about what they're doing that's helping. And so I would like us to pay attention to that, because while we focus on the parent, we're not paying attention to the fact that the children they claim to be helping are not graduating high school, are becoming teenage parents and having their own children placed in the system, that they're becoming also addicted to a substance to mitigate the harm of not knowing who they are, where they come from, the loss of culture, family attachment, medical history. So I would just ask reporters to not take it so lightly when they hear a story about a parent who may have shown some imperfection during raising their child, or when they look at the numbers and see a specific group of people being disproportionately impacted. It doesn't speak to that group of people. It speaks to the people who's targeting that group of people. And we have to ask, why are they targeting these people, and why are they choosing to create these mean narratives about them instead of actually helping? Because if they help, the outcome for the children wouldn't look the way they look. And the outcome for the families who suffer the loss of that child would not look the way they look.
Thanks. Nika, did you want to add on that one?
Yeah, I mean, I think first and foremost, I just wanted to kind of reiterate those policies that focus on pregnant people exclusively, really, and then take those resources that are offered to pregnant people away when they are not pregnant, are effectively pitting the pregnant person against their child. because when the person is not pregnant, the resources are taken away, and what people feel like, what people internalize, what our clients internalize, and what we as providers internalize is we are only taking care of the pregnant person as a vessel until the baby comes out. In particular, then, if people are separated from their children, the fact that those resources are taken away, that kind of emphasis on pregnant people being not worth our time and investing in, and women and people who are able to get pregnant and not being worth our time to invest in is really re-emphasized. I also then wanted to kind of zoom in on hospital policies of just an example of pitting babies and pregnant and postpartum people against each other. All the time, child welfare will at birth recommend that the postpartum person needs to go into residential treatment for a period of stabilization before their baby can join them in residential treatment. That's frequently for people who were using drugs throughout their pregnancy or ready to go into recovery. And for the vast majority of those people who are ready to go into recovery and want to parent, they want to go with their babies. And yet the system says to these individuals who are, again, brave enough to say, I want to go into recovery, I'm ready to take on that challenge. The system says, oh no, we need to protect you from your child for 30 days. You need to prove to us that you are a safe caretaker. When ironically, we look at the medical literature, when we look at babies who are in the NICU, what is the #1 predictor of increased or decreased hospitalization days? It's visits from the birthing parent. So these policies are completely in opposition to the medical literature, which supports dyads being together, birthing people visiting their babies, being close to their babies, breastfeeding once those substances are out of their breast milk. And yet our policies are suggesting that there needs to be this separation from the perspective of the person who is trying to get into recovery. I don't think there's anything harder than being in early recovery and then separated from your newborn. You, are trying to get over the chemical dependence. You're trying to get through those withdrawal symptoms, those cravings, those physically incredibly challenging symptoms. And at the same time, you're having this wild change in hormones. Postpartum depression is way more frequent after child separation. You're not able to allow the natural reinforcement of the baby reinforcing your recovery. So that work of recovery becomes 100 times harder, probably 1,000,000 times harder. And so again, when we pit pregnant people, postpartum people, parents against their babies, it really makes no sense. And we do that because of that longstanding narrative of babies need to be protected from their parents, which just makes no medical sense. And it also makes no sense in terms of supporting people's recovery journeys. It makes no sense in terms of even just supporting the well-being of the baby, as we see from those NICU stays. And certainly in terms of supporting families in bonding and growing together.
Thank you. So we are getting ready to wrap up our discussion part of it. So if any of you all have any questions that you want to ask, please drop them in the Q&A at the bottom of the screen, or you can hit the raise hand button if you'd rather ask your question out loud. I'm also putting links to the longer resource and the one-page reference guide in the chat. So what I'd like to pose to our panelists now is thinking about what kinds of stories would you like to see in the media around these issues? Sarah, do you want to get us started?
Sure. So I'm first going to say what I'd like to stop seeing, and then I would like to throw out what I would love to see. So I think that I would love to stop seeing reporting on information about just the latest study about trends in substance use in pregnancy. There's always some substance that is increasing, and then there's some substance that is decreasing. And that's not actually that newsworthy, in part because the increases tend to be overstated. I'd also like to stop seeing just the constant news studies purporting to show some unique effect of a substance use during pregnancy. I'd like to stop seeing those, and instead just a focus on the policies and healthcare responses that are adopted in response. And in particular, I think there's a huge need for stories building on what everybody has been saying so far of just what are the harms of over-reporting to child welfare? What are the harms of this over-involvement of child welfare, of family separation, and just really focusing on that and bringing attention to that topic.
Right, Jamie, would you like to go?
Sure, thank you. I would like to stop seeing the, first of all, photos of people delivering their baby on the sidewalk. And I don't want to hear stories of adversity without hearing like the positive or the outcomes of, hey, look at where this person came from, look at the path that they traveled down and how hard they had to work to get here. I want to see uplifting the voices of those people and just creating a different culture, creating a different environment. Instead of me being the enemy, I want to be in a place where, hey, I want to reach out when I need help and I want someone to grab onto me and help me. I don't want to be in a place where I'm reaching out and everybody's like pointing at me and laughing at me. So creating an environment where healing, I know I said this already, healing and growing and recovering is what I want to see more of.
Thanks. Joyce?
So Joyce, what I would like to see less of is the sharing of false narratives. What I would also like to see less of or more of is holding the government accountable for the choices that they make that impact communities, that put people facing different concerns further in jeopardy. I would like to see the government be accountable for the way they spend taxpayer dollars, for the way that they care for communities, for the way that they redline communities into poverty. And I would just like to see them be held accountable on more stories about how spending is happening and what would be a better way to spend and to better support the community instead of all of this money going into government that is not dispersing it in a way that's actually helpful, but utilizing it to surveil and punish, incarcerate, separate, judge, and all of the rest of the things. We have to be more caring to have more caring outcomes.
Thank you. And Nika?
I'd like to see more stories on the complexity of what a recovery journey looks like. Recovery is not just about getting someone medication. It took years of intersecting forms of oppression for people to land on the street in a tent using substances, often with PTSD from all of the traumas that they've experienced, including from living on the street. And so it will take years of intersecting forms of support to help that person realize their parenting journey. Part of recovery is returning to use at times, and we need to support people through those periods, similar to what Joyce said, without immediate punitive, either punitive policies in terms of separating families immediately or punitive in terms of putting people in jail. If we're going to approach this condition, which is substance use disorders, as a health condition, which it is, we need to treat it as such. And there are ways to support families for increasing support. For example, going from living in the community to residential treatment with your baby, with your child, that can allow people to continue on their recovery journey, recognizing that this is a relapsing condition that is known to relapse over time. And what we need to do in those situations is to continue the support. All of our policies often end, and supportive policies often end at maybe 6 months, a year postpartum. And it is absolutely absurd to think that people, again, who have experienced their sometimes an entire lifetime of oppressions are going to be in recovery and stable within 1 year.
Thank you, Nika. And I see Alana has a hand up, so should be able to unmute yourself now. Go ahead.
Hi, all. My name is Alana Vagianos. I'm with HuffPost, and I apologize. I'm a little sick. So this has been a really, really interesting conversation. I deeply appreciate all your expertise. I'm curious, and I think you had kind of answered this question and kind of the common mistakes, but I'm curious if there's any common phrases or terminology that you see in reporting and journalism that you wish reporters would stop using. I come to this conversation from the abortion beat and reproductive justice as a whole, and how abortion bans are criminalizing pregnancy outcomes and criminalizing pregnant people. And, one thing I was thinking about when y'all were talking about this is, how a lot of people were using the term late-term abortion, but in actuality, the best term to be using is abortion later in pregnancy. And I was curious if any of you could speak to, specific terminologies or common mistakes that you see in reporting around the subject area that you wish would be corrected.
Thanks, Alana. And I will say that the one-page reference guide, which is also included in longer resource, has a lot of examples of that too for folks to check out. Any of you all on the panel want to jump in on that to highlight some?
I can start just by throwing out 3 that are top of mind that I think is just language. And there's great resources, both in terms of the resource that Rebecca shared and also a whole host of other resources, but just use person first language. So use person who uses drugs rather than drug user. Don't use the word addict, and don't use the word substance abuse. Those are terms that people are really stigmatizing and should be moved away from.
I would like for reporters to stop saying abuse and neglect and begin saying neglect and abuse. I think that's important because the first word being abuse makes it sound like it's more prevalent, and it's not. There's only 13% of children across this nation that's separated from their families for reasons related to abuse. The other 87% are removed for reasons related to poverty that are framed to be neglect. So it's really neglect and abuse, because we don't want to condition people to think that children are just being abused every day. Those are rare occurrences, and we should treat them like they are.
I have a quick one, which is when reporters use the term drug of choice. I've never heard a patient in my clinic or client in my clinic say that their drug use at that moment in time is a choice. It is a substance use disorder. It's a health condition. And for many of these conditions, if they were not using that drug and if they stopped it immediately, that actually could be a life-threatening situation. And so it really is not a choice. It is a drug that someone is using or a substance that someone is using. It's not a choice.
I think everybody covered mine. Thank you.
Great, thank you. And I will also say to Jamie's point earlier, that we also link to some guidance on visuals as well as language for people to keep in mind. So we are just about out of time. So I want to thank you all so much for coming, and thank you so much to Sarah and Nika and Joyce and Jamie for joining us today and sharing your expertise and for helping to shape this resource. We really hope this is the beginning of a conversation with you all, and are always here if you have additional questions, want to connect with experts, want to think through story ideas, please come to us anytime as a resource. So thank you all so much and have a great day.